Welcome, everybody. Thanks for joining us today to talk about making RVUs meaningful in 2021. My name is Scott Everett. I'm the Vice President of Healthcare Solutions here with Practical Data Solutions. I'm joined today by Kelly Constantinidis, who's one of our Senior Business Intelligence Analysts. So thanks for joining me today, Kelly.
Hey, thanks, Scott, and thanks to everybody on the call for joining us as well. If you're not familiar with PDS, we have been working for over 20 years with healthcare clients and working with them to deliver data solutions, including data warehousing, analytics, and visual dashboards.
So if you've joined us for the webinars that we had in the first quarter of this year, obviously we had talked a lot about the changes that were made in the CMS 2021 fee schedule, and we started talking about the revenue integrity that came from that, particularly focusing on denials, which is something that we've seen hit pretty early on in the year. As we move forward throughout the year now, we found that the RVU changes are really starting to show their impact to a lot of organizations. They're really starting to feel the changes that are there. So we're going to really focus on those coming up in the next couple of months' webinars, starting today where we talk about making RVUs meaningful and moving forward with how to get impactful RVU analytics to end users in a variety of different formats.
So as we start to get into some of the visualizations and dashboards, we're going to go ahead and turn our cameras off. And now that we know our 2021 volumes are carrying these substantially higher RVU values, wouldn't it be great if we could do something like this and quickly see what departments or providers are seeing real volume increases versus what may be impacted and appear as volume increases because of the drastic increase in RVUs. So we're going to highlight the significant 2021 CMS changes. We're going to look at some of the reporting challenges we're seeing as a result of those changes, and we'll look at some strategies to model the RVU values. And we're going to take a look at some other key metrics that we may want to consider handling in a customized fashion for ongoing reporting.
So obviously you're probably joining us here today because, again, like you like most organizations and practices are really feeling the changes that have come about through the 2021 fee schedule, the changes that came from CMS. Now, there were some things that were very beneficial about this. Obviously, the expanded telehealth list has really helped a lot of providers, particularly during times of pandemic and things like that. But where the biggest impacts have been seen have been in the changes to the RVUs, particularly with the work RVU components that have been increased in the E&M codes, outpatient E&M codes for new patient and established patient office visits. Some of those went up from 10 to upwards of 30+% in those RVU changes. And in addition to those work RVU components, for those of you who look at total RVUs as well, it was pretty much across the board that the practice expense component has been changed on a lot of these RVUs because of the ways that they've changed the calculations. So obviously with these changes came a decrease in overall conversion factor due to budget neutrality, but conversion factor dropped a lot less due to the COVID stimulus plan. So that's been helpful. But that said, again, the biggest impact that we're seeing are the changes in these RVUs, and that's because RVUs are universal. RVUs hit across all payers. And RVUs are such a key metric that are utilized by our clients and really all practices across the country to measure things like productivity. They're used for budgeting. They're looked at for contracting, reimbursement, and they're really key components in physician compensation. And so this is something that has caused some issues with the changes that we're seeing. In addition to that, I don't know that people really even understand the impact that they can have in analyzing and forecasting things like patient access and quality, and utilizing RVUs when you're evaluating, do you need to expand your practice either through physician recruitment, through acquisition of additional practices, things like that. RVUs are really used a lot to determine things like ramp up time, to determine payback time, return on investment. So really these RVUs are critical, and the problem that's come up is the changes in the work RVU components in particular have been so significant that it's really tough to try to get an apples to apples comparison from one year to the next.
So here we are 4 months into 2021, and 2021 RVU values don't line up with 2020. So we're hearing from our clients some of the reporting challenges they're facing, specific to trending volumes and productivity using RVUs, those clients that use the RVUs for compensation, and then being able to measure the impact that we're seeing to reimbursement. So what we're finding is we not only want to bring in the 2021 new RVU values, because those 2021 values are as published by CMS, and those are what is driving our reimbursement. But we're also finding we need that second set of metrics that reflect 2020 values for comparison. So this allows us to line them both up for comparison when we look at our 2021 volumes. So Scott, this allows us a good amount of flexibility as we start reporting across productivity, across reimbursement data sets. Would you just talk a little bit about how that works in the model?
Yeah, so data modeling on the back end is one of the things that we really do with best practices in mind. We'd like to bring across data from the billing systems, scheduling systems. We can even do external systems like a patient satisfaction or a GL, things like that. One of the best ways we've found now is that we can just import directly the CMS RVU table, and we can import multiple years and store those in the modeling system as well. What that allows us to do is it allows us to be able to have this data that's optimized for reporting in one place, and we can deliver it to end users in whatever fashion the practice deems best to meet their needs. We found that this is a lot more effective than taking it directly out of the billing system itself, taking RVUs out of the billing system itself, mostly because there are sometimes just some inherent weaknesses with billing systems with how they calculate RVUs. And we work with obviously a number of different billing systems out there, and some of them, each of them have a little bit different way that they calculate RVUs, and some of them calculate RVU more by a charge post date rather than by a service date. And so what you'll see there is you'll see charges with like a December service date that January RVUs attributed to those services. A lot of our clients utilize unlisted codes or pseudo codes that are just unique to them that CMS doesn't assign a RVU value to those, and they want to be able to do that. Modifier adjustments, a lot of billing systems either don't do it or they don't do it necessarily in exactly the way the practice would like to see it done. A lot of our clients are very large and have a large geographical area and need multiple gypsy adjustments put in, and a lot of billing systems can't handle multiple systems or multiple gypsies that way. In addition to that, looking at, mid-year RVU rule changes like we saw last year, where there were some particular codes that were low volume prior to the pandemic, but really increased in volume as COVID hit, and they changed the RVU values to those in March. And that was something that a lot of billing systems just didn't accommodate for. And of course, working with all of these different systems, I have yet to see one that will do two at a time. And so that's where it can really help to do this modeling on the back end.
So last fall, when we were evaluating the proposed 2021 RVU change before it became real, we were able to use our existing reporting tools to help us project the impact of the RVU changes as far as it related to work RVU reporting, as well as the reimbursement impact based on the different conversion factors that were being proposed. So we did this based on the limited volume of E&M codes that we knew we were going to be impacted, high volume E&M codes. We were able to create these custom calculations within our existing reporting, kind of on an on-the-fly basis, to help with those projections based on what we thought CMS was going to do with those values. But as we move forward and these have become published now, we need to expand and build on those kind of on-the-fly one-off projections. So here we've got a visual dashboard where we're comparing 2021 against 2020 volumes. And a report like this, we would typically be comparing based on service date RVUs, 2021 versus 2020. And with a quick look at this, I'm seeing in general, division by division, we're seeing significant increases in several departments like cardiology, medicine, pulmonology. And then if we look at our individual provider productivity, they look across the board, and as I scroll down my provider listing, large percent increases as we're looking at it at a provider level. So, just with this view, looking at 2021 RVUs versus 2020 RVUs, through quarter one, I go to Scott and say, hey, we're off to a great year. We get our COVID vaccines. Our RVUs are looking great.
Yeah, and that's a way, that's good to see, because again, that's impacting our reimbursement from CMS the way we'd like to see. But that said, I'd really want to see how that's looking more compared to the volumes that haven't been artificially kind of inflated just due to the changes in the rules. So if we are able to come in and start looking at adjusted work RVUs instead, I can see individually different departments. I'm still seeing a gain in cardiology, which is good, but it's not nearly as pronounced as we saw before. I'm looking at internal medicine, and it's actually a decrease in actual productivity quarter over quarter as we saw previously. If we want to look at it at an individual provider level, these bubble graphs really can give us some great insight. We can look at our high volume providers, and we can see here are the ones who are our highest performers, and we can see the ones who are doing pretty well with their increases kind of across the board where it comes that way. So it's good to see, but if you look at the one to the right, you can see not all of these are increases in actual work effort that's come across. We could additionally go in and look at kind of our lower providers, our lower performing providers, and try to better understand what's feeding into their performance. What are the divisions that they're in, the departments they're in? Are there areas that we really need to address? Is it a volume issue that comes from internal efforts, or is it something that's done on an individual provider basis? And of course, what's really going to give us a lot of insight is I look at this and I want to just go right along that axis there, and I can see right away, here are some providers, and this is going to create a nice little subset of providers there where it looks like they have modest increases in their work RVU productivity through the year. But if we really break it down and look at it, most of those are actually seeing decreases in the amount of work that's performed from year to year. So this gives us a lot of insight and a lot of good things to see, to better understand as an organization what are some areas that we need to address with regard to real productivity versus inflated productivity.
So Scott, I really like how it's easy on those bubble charts to limit that data and be able to focus in on what we need to look at. And while we're talking about the individual providers, I wanted to talk a minute about how to get this information and what to show to our providers on an ongoing basis. So this is a visual web dashboard geared toward the physicians. We have some key metrics, payments, charges, payments, and adjustments that we show on a regular basis. We're bringing in their work RVUs. We're bringing in their benchmark RVUs, and we're adjusting those benchmarks based on their clinical FTE. So if they're a 0.8 FTE, it would adjust that down based on that information. We're bringing in some individual charge lag, as well as down on the left, we're comparing the individual provider charge lag to that of the division average, just to give some context to that information there. So if we focus on the RVUs, right, 2021, we've got a bump up. Everything's looking good there compared to our benchmark for the 2021 months. Well, if we bring in that second set of adjusted RVUs into a view, we're seeing that, okay, yeah, we're still above that benchmark, but we're not doing quite as well as we would just looking at that 2021 values that we started with.
Yeah, and Kelly, one of the things that I like about this, and probably think we need to discuss a little bit, is those who are using benchmarks, unless you're utilizing a service that's going through and recalculating all of your benchmarks kind of the same way we're doing it, those benchmarks aren't necessarily going to be applicable for the new year until they get new data sets in to recalculate those. So it's really very helpful if benchmarking is a big part of your organization to track productivity, to to do something like this, where you can, again, look at what the real productivity increases are and compare those to the benchmark and have more of an apples-to-apples comparison than you would just looking at the 2021 RVUs. You know, one of the things that has really also caused a lot of issues with the clients that we're working with right now is compensation. Physician compensation probably that's based upon work RVUs. We're probably based upon work RVU tables from years ago, you know, prior to 2021. And so when you look at things like RVU tiers, when you look at the different compensation plans that are probably out there, those didn't accommodate for the changes that came across in the 2021 rule. So one of the things that can be done is you can actually go in and you could go and do exactly what we're doing here and incorporate those adjusted benchmarks into your compensation reports that you're distributing. Now, there may or may not be a lot you can do about the compensation plans that you have in place, but it's definitely something good to know as you go forth and possibly look at modeling new compensation plans or compensation plans that you're going to bring new providers in on. You're going to want to know the differences that you're seeing, and you're going to want to set up your tiers more appropriately with regard to the new RVU values that are out there, or at least set them up according to older systems and include those in your contracts. One of the things that a lot of clients are doing as well is they're starting to weight the RVU productivity even a little bit less and start looking at other types of metrics that go into compensation. And so that can definitely be helpful too, so that you're not caught off guard with something like this, but it makes it even a little bit more difficult when you're looking at all of the different data points that are out there, and what if you need custom type metrics.
So as we saw in those other dashboards, we're able to create consolidated reporting by combining several different data sets, whether it be benchmark data, patient satisfaction data, if we want to bring in general ledger data and things like that. So we take the approach of using the star schema structure to join the data sets together. And this allows us to build out those visual dashboards by integrating and blending all these different data points for that end user reporting.
Yeah, and really what's nice about this is it does give you the ability to join across these different sets, but making sure that you set it up right, because this helps you to really kind of validate as you go along. If you do it wrong, there's a lot of times issues that can stem in performance. There's problems with the ability to join data sets. Setting it up this way really helps to kind of overcome those problems that you may see. Some of the things that we've been asked to look at a lot of times are, you know, custom type metrics that we've talked about before, where it's similar to RVUs, where we may need more than one type of thing to look at, or we may need to highly customize it in order to make it what the organization wants to see. So I look at something like a visit. We probably see a dozen different visit definitions across all of our clients when we're trying to stage a definition of what actually encompasses a visit. Or you can have a visit versus an encounter versus a case. And all of these may need customized definitions, and that back-end modeling is what allows us to do that. Similarly, we do a lot with denials, where we can do some customizations and some calculations and some categorizations, which can help with some efficiencies there. And then when you're looking at maybe working with multiple billing systems, utilizing the star schema and the ability to join the data sets is what allows you to be able to bring those into those visual dashboards and be able to create the modeling and the visuals that your end users need to see that way. So let's take a look real quick at, you know, kind of an example here of a visual dashboard. This is just kind of a basic OBGYN dashboard that you might see, but what you might have here is we've incorporated visits, we've incorporated work RVUs, and because we've done the star schema, we were able to bring in, you know, patient satisfaction as well. So when we look at things like that, we could even incorporate now the adjusted work RVUs and bring those in very easily to a dashboard like this.
Here we have another specialty-focused dashboard, and this is for a general surgery practice. We have some of the same metrics. We're looking at surgical cases, we're looking at our new patient volume, and we're looking at the length of time it's taking to get those patients seen in the practice. We also have RVUs on this particular dashboard, so a valuable add here could be that second set of RVUs.
Yeah, so you can bring these into like a web-based dashboard as well, where, again, the STAR schema allows us to bring things across different data sets, and we can look at lots of different ways. And then, of course, if we do it right, then it gives us all of this interactability with the end user. So you can see this is one where we were able to bring in work RVUs, but then we also have visits, we have procedures, we have cases. All of these may have different definitions as defined by the practice itself. But because we've utilized that STAR schema, we're able to go in and not only work in this, but we can go through and we can bring it down to maybe a more analyst type user who sees the information that's there and wonders why and wants to start digging and better understanding, slicing and dicing through the data, being able to quickly apply filters and calculations and things like that to get to where they need to go. And of course, since we've taken raw data, placed it into the STAR schema, we can then go through and we can really easily and quickly drill down into the detail level organization, that patient level, invoice level. When we need to get to that, all of that can be brought in just through a very simple process as long as it's staged in the proper way. So let's talk a little bit about denials and some of the customizations that have been done there. Again, denials is something that we've seen a lot of problems with the new CMS rule. And it's something that a lot of our clients have asked for some additional customizations on, particularly in the area of categorizations of the denial codes. A lot of times billing systems, you can have a lot of different categories that are out there, and some of them want to just drill them down or bring them down to a handful of different categories because of the way that they set up their work files within the organization. They can also do another type of categorization to do high impact or low impact. High impact is what do we in the practice have a lot of control over. Low impact, what do we not have very much control over. And of course, we can eliminate a lot of noise by just getting rid of those informational only denials that we're not going to do anything about. So looking at things like this can really bring some efficiencies in the way that organizations are working denials. In addition to something like this, you may want to take a different perspective in the way that you look at denials, where a lot of times people look at denials based upon when they're posted within the system. Sometimes you may want to look at it on more of a matched basis, where you can match the denials back to the individual charges that generated them. What that's going to help you do is that's going to help you get more accurate denial rates, allow you to look at maybe more trouble spots that have hit during times and look at different spikes and dips that need further attention from the management staff or the revenue cycle team that's out there. The other ability this gives you then when you're doing it on a matched basis is it lets you look at what happens on the back end, what happens after the denial, so that you can look and see, well, this was denied, but we've subsequently recovered this amount, and that helps us to really look at kind of an effective net denial rate of what is denied that we really didn't get paid for, or what was denied that we did get paid for, it just happened to be a little bit more slowly. So all of these perspectives can definitely help a management team and a revenue cycle team be a little bit more efficient in what they're trying to do and really maximize the cash that they're bringing in, either through prevention or recovery efforts.
This is a dashboard that really ties everything together and highlights the use of the STAR schema approach. So here we're bringing together financial data, we're bringing in appointment data, we're bringing in patient satisfaction data sets down to all the way down to the provider level. And then to take this a step further, we're actually combining key measures for two separate practice management systems. So for those of you that may have practices that are on multiple practice management systems, or maybe are migrating across practice management systems, this allows that ability to join those data sets and get that historical and trending data across those key metrics. This would be a good place where we could bring in those adjusted work RVUs, since we have the work RVUs as one of our key metrics here.
Yeah, so I think what we're really trying to underscore with these different customizations that are out there is the overall philosophy of how you go with from getting the raw data that comes out of the applications themselves and really transforming that into data marts that are better optimized for everything. And if those are set up correctly, the analytical tool that you use can really be whatever your organization feels is best. You can utilize MicroStrategy, IBM Cognos, Microsoft's Power BI, Tableau, Click. Any of those different tools will work efficiently on an optimized data structure that's the star schema. I think at that point the challenge more becomes, how do you extend that out to the end users who can best use that to effectively drive change within the organization? So a couple of key takeaways that I'd like to hit. Obviously, these CMS changes have made a lot of impact to organizations, and obviously the reimbursement changes with CMS have been big. Some of the denial changes have been big, but really those RVU changes are really exceptional. There's something that I haven't seen in over 20 years working with revenue cycle, and it's made overall year-to-year comparisons just really challenging. So because of things like this, there really is a definite benefit to possibly staging multiple sets of RVU tables within your data models that are out there. It may be modeling to 2021 volumes to 2020 RVUs. It may be modeling with some additional customizations that are in there. It may be modeling more to a comp plan that you have set up or you'd like to set up. Looking at RVUs as several different ways can definitely bring some benefits to what you're trying to do and the overall strategy that you're trying to formulate. And then, of course, the best practice data staging is what really allows you to do all of these things. It's what allows you to do all of the different customizations that are out there and report on metrics, and it allows you to do it right. And, I like to harken back to John Wooden, who one time said, if you don't have time to do it right, when will you have time to do it over? Thanks, everyone.
Have a good day.